Good day and welcome to this case discussion on secondary amenorrhea and premature ovarian insufficiency. So we have this case, a 35-year-old G2P2-2002 who consulted because of amenorrhea of 6 months, no medications taken. She has normal BMI with an MFG score of 2, no acne. Her pelvic exam is normal. And she has this following laboratory results. So her TSH is at 6.0 milliunits per liter, prolactin at 25 nanograms per ml, estradiol of 16 picograms per ml, FSH of 33 MIU per ml, and a transvaginal ultrasound showing normal size uterus with a 0.4 centimeter endometrium, and the ovaries are normal in size with no follicles. So the TSH levels typically fall between zero point 0.4 and 4 milliunits per liter. That's according to the American Thyroid Association. So ranges between laboratories will vary, with the upper limit being 4 to 5. Now, obviously, in this case, our patient has elevated TSH. Estrogen or estradiol levels are considered low when the range is around 10 to 20 picograms per ml, and this can be caused by menopause, anorexia and Turner syndrome, and extreme endurance exercise can also reduce estradiol levels. And some of the symptoms of low estradiol levels are fatigue, hot flashes, night sweats, vaginal dryness, and difficulty concentrating. And low levels of estradiol can leave you or a patient feeling depleted and exhausted. So the normal range of prolactin is 2 to 29 nanograms per ml. So this is normal. And the FSH here is obviously elevated. So normally, if the FSH is elevated, 20 MIU per ml, that is usually indicative of menopause. And here, for a 35-year-old patient, uh, ovaries with no follicle seen is quite abnormal. So question number 1, how should a patient with secondary amenorrhea be worked up? First, let's define what is secondary amenorrhea. Secondary amenorrhea is the cessation of previously regular menses for 3 months or previously irregular menses for 6 months. So how do we evaluate a patient with secondary amenorrhea? First off, of course, you know this, we have to rule out pregnancy first. And if she tests positive for the pregnancy test, then you have to manage her accordingly. If the pregnancy test is negative, then we assess the patient based on history and physical exam. Does she have weight change, eating disorders, excessive exercise, galactorrhea, hot flashes, systemic illnesses, history of uterine instrumentation, or on physical exam, does she have low BMI or is she obese? Does she have signs of hyperandrogenism or galactorrhea? Now, the 4 basic lab tests that are very important in the evaluation of secondary amenorrhea will be these 4, no? FSH, estradiol levels, TSH, and prolactin. Now, we can also add serum total testosterone if there is evidence of hyperandrogenism. Now, if the prolactin is elevated, of course, that will be hyperprolactinemia. And the next best course will be to request for pituitary MRI or CT scan. If the prolactin is normal, look at the TSH. Now, if the TSH is abnormal, then you treat the thyroid disease accordingly. If the TSH is within normal limits, then look at the FSH. If the FSH is elevated, now in the setting of amenorrhea, high FSH is seen with low estradiol, and hot flashes and vaginal dryness are also common. So probably our patient may have premature ovarian insufficiency. Now, if the FSH is low or normal, or if the estradiol is low, then our patient may have hypogonadotropic hypogonadism or functional hypothalamic amenorrhea or a systemic illness or other hypothalamic or pituitary disorders. Now, in this case, you might want to order for a pituitary MRI to rule out a stellar mass. Now, if the patient has low or normal FSH and the estradiol levels are not low or within normal levels, then check for evidence of hyperandrogenism. Okay, if she has evidence of hyperandrogenism, then PCOS is a most likely diagnosis. If there is no hyperandrogenism, then all lab results are normal, and there's history of uterine instrumentation, then probably we can perform a progestin challenge test or an estrogen progestin challenge test or hysteroscopy to rule out intrauterine adhesions. Now, this is another a nice algorithm on the evaluation of secondary amenorrhea. As you can see here, no, it shows us the same basic laboratory test to request for in a patient with secondary amenorrhea. Again, this is estradiol, FSH, prolactin, and TSH. If the prolactin is high, then you evaluate for hyperprolactinemia. If the estradiol levels are high or more than 30 picograms per ml, then request for ultrasound. If there's evidence of PCOS, then you can request for testosterone, DHEAS, especially if the patient is hyperandrogenic and PCOS. And if she has normal ovaries, then consider hypothalamic dysfunction, unless with a history of drug ingestion, severe stress, or weight loss. If the estradiol levels are less than 30 and FSH is normal or low, then consider hypothalamic pituitary failure and look at the TSH levels, or maybe you can request for MRI or CT scan of the central nervous system or ACTH reserve test. If the FSH is high, then consider premature ovarian failure. Now, in this case, remember our case, our patient has low estradiol levels and high FSH levels, then we are now considering a case of premature ovarian failure or premature ovarian insufficiency. Now, here are the more common causes of secondary amenorrhea. So as you can see here, for a patient with low or normal FSH, we can consider weight loss or anorexia, non-specific hypothalamic lesions, hypothyroidism, Cushing syndrome, or pituitary tumor, empty sella syndrome, or Sheehan syndrome. Secondary amenorrhea can also be caused by gonadal failure, high prolactin, anatomic causes such as an Asherman syndrome, and hyperandrogenic states. Now, let's go back to our case. So our patient is a 35, sorry, this is not 40, a 35-year-old G2P2, amenorrhea of 6 months, high TSH, high FSH, low estradiol, normal prolactin, with an ultrasound finding of a thin endometrium at 0.4 centimeters and no follicles noted. So our diagnosis, given the algorithm that I showed you a while back, is premature ovarian insufficiency, and consider autoimmune or Hashimoto's thyroiditis because this is the most common cause of POI, and also because our patient had elevated TSH levels. Now, what is premature ovarian insufficiency? Premature ovarian insufficiency is a clinical syndrome defined by loss of ovarian activity before the age of 40. And POI is characterized by menstrual disturbance, that is amenorrhea or oligomenorrhea, with raised gonadotropins or low estradiol, particularly high FSH. The prevalence of POI is approximately 1%, and population characteristics such as ethnicity may also affect the prevalence. Now, the term POF is medically inaccurate. POF stands for premature ovarian failure. That's why most experts now are advocating the use of premature ovarian insufficiency instead, not premature ovarian failure. So the term POF is very misleading to patients. And for many patients, this POF term, is both offensive and psychologically hurtful. Now, the term POI, or premature ovarian insufficiency, more accurately captures the nature of ovarian dysfunction, which is displayed in affected women, and 50% of whom experience infrequent ovulation and menstrual cycles after diagnosis, and 5 to 10% of these women may actually achieve spontaneous pregnancies. And therefore, because of this, the ESHRE, or the European Society of Human Reproduction and Embryology guidelines, recommend the term, or the use of the term, POI, or premature ovarian insufficiency, to describe this condition both in research and clinical practice. So POI describes a spectrum of declining ovarian function and reduced fecundity due to a premature decrease in initial follicle number, an increase in follicle destruction, or poor follicular response to gonadotropins. The term POI as I've already mentioned, more accurately captures the nature of ovarian dysfunction displayed in affected women, with 50% of whom experience infrequent ovulation and menstrual cycles after diagnosis, and 5 to 10% of these women actually can still achieve spontaneous pregnancies. What are the typical symptoms or the clinical presentation of patients with POI? So the typical symptoms of estrogen deficiency, such as vasomotor symptoms, are typical in these patients, and clinical presentation may be variable. Symptoms may intermittently disappear due to fluctuating ovarian function, and this, however, does not exclude a diagnosis of POI. Some women with POI may not experience any symptoms at all, and women may experience sudden severe symptoms upon cessation of the contraceptive pills, and symptoms are less likely in young women with primary amenorrhea. Now, there are two main histopathological types for POI, and this is the type 1 or the afollicular type, and the type 2 are the follicular type. Type 1 or afollicular type is when the ovarian follicles are completely depleted. So this is most likely the diagnosis for our patient. So this is associated with gonadal dysgenesis, chromosomal aberrations, and sex development disorders. And the lack of ovarian follicles is due to absence or failure of the germinal cells to develop. Type 2 or the follicular type, the ovarian follicular structures are preserved and therefore ovarian function may return. So there are many causes of POI, and this includes genetic disorders or chromosomal disorders, autoimmune diseases, and even chemotherapy, radiation, infections, and surgery. But the most common cause of POI will be idiopathic, or means that most of the causes or the etiology for POI remain unidentified. So we have also the primary POI and the secondary POI. As I've already mentioned, the primary POI may be secondary to chromosomal abnormalities or an FSH receptor gene polymorphism and inhibin B mutation, enzyme deficiencies, or an autoimmune disease such as Hashimoto's thyroiditis. POI can also be secondary to chemotherapy and radiotherapy, bilateral oophorectomy or surgical menopause, hysterectomy without oophorectomy, or uterine artery embolization, and infections such as mumps. Approximately 20% of patients with POI have been previously diagnosed with other concomitant autoimmune diseases, and the most common would be disorders of the thyroid, adrenal, and pancreas. But in the majority of cases, the etiology is unknown. Up to 40 to 50% of women with POI are positive for at least one organ-specific autoantibody, and the most common being thyroid peroxidase antibody and anti-thyroglobulin antibodies. There is an increased incidence of gonadal insufficiency observed in patients with autoimmune disorders such as primary adrenal insufficiency or Addison's disease, autoimmune thyroid disease or it's Graves or Hashimoto's disease, and various gastrointestinal diseases. So autoimmune diseases that are associated with POI can be endocrine or non-endocrine diseases. So under endocrine, we have the thyroid disease, Addison's disease, hypoparathyroidism, hypophysitis, and diabetes mellitus type 1. The non-endocrine etiologies may be chronic candidiasis, idiopathic thrombocytopenic purpura, vitiligo, alopecia, autoimmune hemolytic anemia, pernicious anemia, SLE, rheumatoid arthritis, Sjogren's syndrome, primary biliary cirrhosis, chronic active hepatitis, and celiac disease. For the thyroid diseases, so thyroid autoimmunity is the most prevalently associated endocrine autoimmune abnormality reported in patients with POI without adrenal autoimmunity. The presence of high levels of non-ovarian thyroid peroxidase antibodies leads to the development of clinical and subclinical hypothyroidism. Thyroid autoimmune disease, most commonly Hashimoto's thyroiditis, is present in 17 to 27% or 14 to 27% of women at initial diagnosis of POI. And it is reasonable to measure thyrotropin levels and test for the presence of thyroid peroxidase antibodies. Now, all women with thyroid autoantibodies should be referred to an endocrinologist for additional evaluation and long-term follow-up. The reported concurrence of thyroid disease with diabetes mellitus is about 2.5%. So, question number 2, discuss a systematic approach in the diagnosis of POI. Now, the ESHRE guidelines tells us that the diagnosis of POI is based or must be based on the presence of menstrual disturbance and biochemical confirmation. So, this would be oligo or amenorrhea for at least 4 months and an elevated FSH level of more than 25 IU per liter on 2 occasions more than 4 weeks apart. Can we do ovarian biopsy, or is ovarian biopsy important? Now, ovarian biopsy is of course the gold standard for detecting autoimmune involvement of ovarian tissue and the presence of developing follicles. However, ovarian biopsy is invasive and expensive. It is also questionable whether an ovarian biopsy accurately represents the follicular density of the entire ovary, particularly in idiopathic POI characterized by variable degrees of ovarian function preservation. Now, how do we diagnose premature ovarian insufficiency? Of course, I've already mentioned the diagnostic criteria, which is oligo or amenorrhea for at least 4 months and FSH levels of more than 25 IU per liter at least 4 to 6 weeks apart on 2 occasions. Of course, we also look at the history and physical examination. Of course, usually these patients will present with chemo or radiotherapy, pelvic surgery, signs of autoimmune disorders, or signs and symptoms of a specific phenotype, especially in a patient with Turner syndrome. Uh, for a non-iatrogenic POI, we may be considering this laboratory test like karyotype testing, Fragile X testing, and antibody testing, especially for thyroid antibodies, 21 hydroxylase, or adrenocortical antibodies. And of course, don't forget pelvic and or vaginal ultrasound. Here is a very nice table showing to us the laboratory tests and why and the rationale behind them. So of course, no, as I've already mentioned, in a patient with secondary amenorrhea, it's always very important to rule out pregnancy first by, asking or requesting for a pregnancy test, or if you like, human chorionic gonadotropin. We can also request for FSH, no? As I've already mentioned, FSH is part of the basic laboratory request that we should ask for a patient with secondary amenorrhea. And this is to assess hypothalamic pituitary ovarian axis. We can also request for AMH to assess ovarian reserve. We can request for a karyotype or fragile X mental retardation premutation to evaluate for genetic etiology. TSH, thyroid peroxidase antibody, and 21 hydroxylase antibody to evaluate for the thyroid function, quantify the risk for thyroid and adrenal dysfunction. And of course, a request for transvaginal ultrasound to evaluate antral follicle count to assess ovarian reserve. We can also ask... Okay, question number 3. What is the management of POI? POI is a diagnosis that requires multidisciplinary management. So before we start the treatment, it would be best to screen our patient for osteoporosis risk factors, CVD risk factors, psychological risk factors, pre-existing medical conditions or comorbidities, and to her BMI and vital signs. It is also important to request for baseline laboratories such as renal function test, liver function test, bone mineral density test, and vitamin D levels, and a fasting lipid profile and fasting plasma or glucose or HbA1c. In women with primary ovarian insufficiency, systemic hormone therapy is an effective approach not only to treat the symptoms of hypoestrogenism, but also to mitigate long-term health risks if there are no contraindications to hormonal treatment. Hormonal therapy is indicated to reduce the risk of osteoporosis, cardiovascular disease, and neurogenital atrophy, and to improve the quality of life of women with POI. Now, in contrast to treatment of postmenopausal osteopenia or osteoporosis, which focuses on bisphosphonates as first-line therapy, low bone mass in women with POI is managed most appropriately with HD. Now, if a patient does not want MHD, or if MHD is contraindicated, then these are the non-hormonal treatments that we can offer. Of course, part of our management will be lifestyle management, such as to cease smoking, encourage regular exercise, healthy weight, diet, adequate calcium intake, adequate vitamin D intake, and reduce alcohol intake. We can also institute some complementary therapy. And of course, if the patient seeks to pursue fertility treatment, then you refer this patient to a specialist. Part of the treatment will, of course, be counseling and refer a patient to a psychologist or a psychiatrist. And of course, um, managing or monitoring her bone health. Okay, so for these are the options that we can give in terms of menopausal hormone therapy, and transdermal, oral, or occasionally transvaginal estradiol in doses of 100 micrograms daily is the therapy of choice to mimic a physiologic dose range and to achieve symptomatic relief for patients with POI. Now, the addition of a continuous or sequential progesterone is protective against endometrial hyperplasia and endometrial cancer, which we all know are risks of unopposed estrogen. Now, we can also use oral estradiol. However, this increases the potential for thromboembolism relative to transdermal estradiol due to the first pass effect on the liver. Some may ask whether we can give oral contraceptives as a form of hormonal therapy. Well, oral contraceptives contain higher doses of estrogen than are necessary for hormonal therapy, and therefore, oral contraceptives are not really recommended as first-line hormonal therapy for these patients. Treatment for all women with POI should continue until the average age of natural menopause, which is around 50 to 51 years old. So how do we monitor patients with POI? Of course, we can monitor them using mammogram, pap smear, yearly TSH if a patient tested positive for thyroid antibodies, and of course, bone density monitoring. For counseling, if the patient tested with negative results or abnormal results for karyotyping, then it's very important that we refer her to an endocrinologist, a cardiologist, and of course, a geneticist. Also, for patients with ACA 21OH antibodies and TPO antibodies, we can refer them to an endocrinologist so that they can be managed accordingly and monitored appropriately. Now, what are the consequences of POI for fertility? Women with POI should be informed that there is a very small chance for spontaneous pregnancy, and women with POI should also be advised to use contraception if they wish to avoid pregnancy. What fertility interventions are effective for these patients? Now, we must inform patients with POI that there are no interventions that have been reliably shown to increase ovarian activity and natural conception rates. And for this subset of patients, oocyte donation is an established option for fertility in women with POI. And we must inform these women considering oocyte donation from sisters that this carries a higher risk for cycle cancellation. And for women with established POI, the opportunity for fertility preservation is missed. Now, what about those women who do not desire pregnancy? Now, combined hormonal contraceptives can prevent ovulation and pregnancy more reliably than hormone therapy alone. For a woman who prefers non-estrogen containing contraceptive and wants a highly effective contraception, insertion of an IUD or an LNG IUS is preferable to oral progestin therapy. Now, what are the implications for relatives of women with POI? The relatives of women with fragile X premutation should be offered genetic counseling also, and of course testing. The relatives of women with non-iatrogenic premature ovarian insufficiency who are concerned about the risk of developing POI should be informed that currently there's no proven predictive test to identify women with who will develop POI eventually, unless, of course, a mutation known to be related to POI was detected in our index case. There are no established POI preventing measures, and fertility preservation appears as a promising option for these patients, although studies, of course, are lacking for now. And their potential risk for earlier menopause should be taken into account when planning a family. So, in summary, Secondary amenorrhea is a cessation of previously regular menses for 3 months or previously irregular menses for 6 months. In general, at a minimum, initial evaluation of amenorrhea or secondary amenorrhea should include pregnancy test and measurement of FSH, prolactin, estradiol, and TSH. Diagnostic, Diagnostic criteria for POI will include oligo or amenorrhea for at least 4 months, plus elevated FSH that's more than 25 IU per liter on 2 occasions, 4 to 6 weeks apart. For non-iatrogenic POI, we also may request for karyotyping, fragile X testing, antibody testing, particularly thyroid antibodies, anti-TPO, and adrenocortical antibodies, and of course, pelvic or transvaginal ultrasound. Systemic hormone therapy is an effective approach to treat the symptoms of hypoestrogenism and to mitigate long-term health risk if there are no contraindications to treatment. Transdermal, oral, or occasionally transvaginal estradiol in doses of 100 micrograms daily is the therapy of choice. Then we add cyclic or continuous progesterone to protect our patient against endometrial hyperplasia and endometrial cancer. Treatment for all women with primary ovarian insufficiency should continue until the average age of natural menopause, which is around 50 to 51 years old. Thank you for listening to this lecture. Good day.